So I'm Marika, and I'm the administrator with Hospice of Missoula, and I know a lot of you, but there are some new faces, so I'm glad that we have some people that are attending that are engaged in community conversations. As you know, community conversations happen on the third Thursday of every month, and I will be doing the introductions today, but before I do, I would like Greg, who is our chaplain of Hospice of Missoula, to sort of talk about the rules of the community conversation. He does such a great job, so.
Thanks.
So there you go.
Thanks, Marika. You know, I don't consider them rules, but just things to hold lightly while we're discussing, because when we sit down to discuss or have a conversation, sometimes we slip into a habitual way of conversing where when somebody's speaking, we might already be preparing what we want to say, kind of either a rebuttal or a, oh, that makes me think of something, and just waiting until that person's done so we can speak. So instead of doing that, just bringing a little intentionality into the conversation. And what Marika is referring to are the 4 guidelines as outlined in The Way of Counsel by Virginia Coyle. And those 4 practices or guidelines are very basic. And the first is to speak from the heart. So when it's our turn to speak, if we have something to say, to allow it to come from our heart and not just from our heads, not just expounding on what we already know, but discussing kind of how we're moved, how we're feeling about that situation. So speaking from the heart would be number 1. And number 2 is to listen very deeply. So when someone is speaking, taking a moment to actually try to listen to what they're saying. Try to hear their heart with your own heart so that we can have a warm connection just by listening to one another. And the third part of that process is to be spontaneous. And that goes along with that listening deeply and speaking from the heart. If we're preparing what we're going to say next, we're not really being spontaneous. Because we might be surprised at what we say if we don't plan it ahead of time. We might say something that we didn't know was inside of us, or maybe something that we would feel uncomfortable sharing if we had thought about it. So being spontaneous. And then the 4th is, since we are a somewhat large group and our time is limited, to try to be brief when we speak. Another way of thinking it is try to get to the essence of the what you would like to say in as few words as possible. For some people, it might be 10 minutes to get to their point because maybe that's just what they need to do. And for some people, it might be just a word or a sentence. It's going to vary from person to person, but just holding that intention to speak from the heart, listen deeply, to be spontaneous, and to be brief and mindful of other people's time. So those are the 4 intentions. And by the time we finish, they may go away, which is fine. But it's nice to start that. Thank you.
Actually, no, there will be a penalty. You pay $5 if you break these rules. So today we have 2 very special guests from Utah. These are this is Gary Holland, and he is the medical director for Hospice for Utah. And they're also starting a palliative care program there. So he's going to talk a little bit about the difference between hospice care and palliative care, how he does both, how they are sort of intertwined, and then to take them apart and see what they look like separately. And Alethea is the administrator there, and she's also a social worker. So she's worked with Hospice for Utah for, gosh, how long? 13 years. A long, long time. So she has a lot of experience there too. So it's nice to have both of them to really share their experiences that they've seen in Utah, for sure, doing the same type of work that many of us do. But hospice and palliative care, I think, is something that we can all experience at some point in our life. So it's great information for everyone. So I will let you take the floor.
Right. Okay. So I've been asked to speak a little bit about palliative care. That's going to be our focus tonight. And I think if we're going to start with that, just trying to understand where the word came from, it's derived from the Latin word Palliative, which really means cloak or to cover. And so when you look at palliative care, the idea is to cover or alleviate or relieve. Those are some of the verbs that are used. A disease process, a symptom, a situation. And so it can, one of the definitions that I also found in researching it was to apologize or make excuses. Now that's not what we want to do in palliative care. I find those things annoying when that happens. So we're really going to focus on the decreasing, alleviating sometimes it would use the word the violence of a disease process or a situation. Because many times in medicine we run into situations and problems and things that are affecting people's lives in a very dramatic way, and we can't really get a label on it, so it doesn't necessarily have to be a disease. It can just be a situation, and most of the time that's what we run into. So with palliative care, the idea is to be looking at a patient not from the standpoint of this is something I'm going to cure, but this is something that this situation, this havoc that's been wreaked upon you by a disease process, I am going to try to make that better for you. And that could come, all physicians obviously practice palliative care, we hope. Certainly some have more of that in mind than others. Whether you're giving someone a little ibuprofen because they have a headache, or a little morphine because they have a broken leg, or some Phenergan because they have the stomach flu. All of those are just examples of palliating something. None of those things help really anything get better. It doesn't help your bone to heal by giving you morphine, but it sure makes the patient feel better. So that's really becomes the goal. And when you look at the difference between what palliative care and just traditional American medicine is, there's certainly elements of palliative care, I think, in any treatment that a physician is doing. When you look at the Hippocratic Oath to first do no harm, and then the second really is to relieve pain and suffering as physicians. But many times as physicians, we have certain limits or goal or things that we are concerned about going to a certain place, and the reason we don't want to go to that certain place is because it may affect the patient's health down the road, or that they may have may decrease the outcome of curing that we are trying to accomplish. And so you might occasionally actually get a patient in the emergency room who is really hurting badly. It could be any type of bad trauma, or it could be a heart attack, and you hear the physician say, well, I've already given him 10 milligrams of morphine, I can't give him any more than that. And the guy's sitting there screaming on the table. Well, a palliative care doc, he'll just never say that. I think also with palliative care, the idea is to think of multiple modalities. In medicine, we're doctors of medicine. That's what we do. We prescribe medicine. And one of the interesting statistics, my father was a physician and a very fine one, and he said when he went through med school in the late 50s, early 60s, there were 4 drugs that were disease specific, like digoxin to slow the heart down. That would be it, okay? So you got 4 drugs. How many drugs do we have now? My gosh, we have 4,000 drugs for every disease process. And then all of them have 6 names. It's a daunting task. But we're doctors of medicine. And so when I have a patient that comes and starts to talk to me about things, and it becomes terribly obvious in the first few minutes that they don't like medicine, and they don't take medicine and don't prescribe me any medicine. You know, you just kind of see most doctors will just start to shrink because we're doctors of medicine, you know? I'm not a carpenter, I mean, things like this. I mean, there are other things that some doctors do. Surgeons, they intervene, they cut things out, they put things back together. But, you know, when you're not surgical, then you are a doctor of medicine. We use a lot of medicine. And so that's something, but as a palliative care doc, that's really just one modality that we use, medicine. And when we look at palliative care, we look at it also as a team approach and not something that just the physician is involved in. And so I'm going to actually let Alethea speak for a few minutes and just let her talk about some of the other modalities that are used in palliative care to help alleviate pain and suffering.
So some things that we have found through the many years of working with patients with his geriatric practice and hospice for Utah is that a lot of times you will see a lot of the patients who will maybe go to the hospital more frequently when there really isn't, maybe it's just a pain in the stomach or their leg is hurting, and they're coming back more frequently. But we're finding that, and we've done some research that a social work visit or a chaplain visit to help alleviate some of the loneliness, the sadness, that really those are the major factors that then the pain levels are lower and they maybe don't really have that pain. I'm not saying that it's not real, but emotional pain and spiritual pain can sometimes be even greater than physical pain. And so with the palliative care program, Medicare doesn't reimburse for the chaplains, but they will for social workers. And we have a chaplain who has donated her time, but he had a patient who she was talking about suicide, she was unhappy, she was fearful that her children were taking her money, and the chaplain went in, and the daughter called after the chaplain left. She had spent about an hour and a half with her, and that patient had a sense of self-worth. She was calmer. She just felt like she was a part of something. She had just moved here, and so she's going to continue the visits. But there's really a lot more, I think, than, when you have our parents who are at home alone. They raise their children. They're not working. They don't have activities because they're limited in their ability to be able to get out and do things that are fun. But they don't have funding to live in a nice assisted living and have a community. So then our minds, we're here and we're not interacting as much as we'd like to with our kids. They have busy lives. And so then we see an increase in depression, an increase in having a decrease in just a lot of daily activities. So we're working to hopefully provide the LCSW to provide some support and counseling for some of those patients.
Great, thanks. So when we are thinking about palliative care, we think, well, what patients are good patients for palliative care? And then I'll kind of contrast that and also kind of blend that with, with hospice. I think that probably hospice is maybe a little better understood, and really the whole palliative care movement kind of started out of the hospice movement in the U.S. When hospice became really took off in the 70s and especially in the 90s, once we had the Medicare benefit for hospice, then we started to see care, end-of-life care, in a different light. And so really palliative care can be seen as hospice care for someone who is not dying. In order to be a good hospice patient, you have to have two things. You have to have a disease process that is going to take your life in all likelihood in the next 6 months, or if you're a cancer patient, in the next 6 minutes. No, that was a joke. Because you don't get cancer patients really until the very end of life. But really, the last 6 months of life is what the Medicare benefit says, and you also have to have a patient and a family that has the attitude that we want comfort, palliative care, and not curative care. I mean, if you have a patient who is dying of cancer, but if that brain transplant becomes available next week, they're on the list. You know, that's not the attitude that's really going to work very well with hospice. And so I think physicians and families and people start to see that, golly, when my mom went on hospice and the focus became on mom and not on her disease, when it became to try to make her nausea and her energy better rather than to make that tumor smaller, then her quality of life improved, and she did very well. And so why does that have to be limited? Why does that goal and that type of symptom management have to be limited to people that are just on hospice? Well, it doesn't have to be. And so the idea of palliative care is to really provide that type of care for people who are getting to the point where they are either struggling with a chronic disease or the chronic disease of age. But generally, these are folks who have gotten to the point where they are dealing with a long-term life-limiting process and needing help. And so that's really where palliative care comes in, to try to support that person. My practice is primarily home-based practice. I don't have an office that I see patients in. I go out and see them either in assisted livings or in their home. And because there's a huge population out there of people that it's just darn hard to get to the doctor. And so that's where I try to start that. And many of the people, if you're debilitated enough that you can't get to your doctor, then you're probably meeting those criteria that you're struggling with chronic disease or debility, and you are needing some good medical management. I like to think of it as just very good common sense medicine. But common sense is not very common in medicine, if unfortunately, it's just not. I mean, we don't do things. And a perfect example of that would be like one of my good friends who's an orthopedic surgeon, and his attitude is when that 90-year-old blind diabetic lady on dialysis rolls out of her nursing home bed that she's been in for 10 years and breaks her hip, then you've got to operate on that hip. It would be better she die on the table than not fix her hip. And I'm sorry, that doesn't make sense, but that's his attitude, because he just doesn't believe that you can provide good quality care, without stabilizing that hip. And so, and I must admit, the deeper you get into the specialties, that they're dealing with that microcosm of the body, their attitude just gets more and more amplified in that way. And then you just start to lose some common sense. Whereas we just try to sit back and say, what's really the best, for the patient? And overall, what's going to serve, the patient the best? And not, necessarily, my specialty. Let's see, what else did I want to talk about?
A few things that we have talked about just in the last year of adding to his practice are having the DME company who can go out and do falling safety risks. They do them free. They go and evaluate them and say, these are some things that you can change in your home so you're not a fall risk. We have a pharmacy that we've worked with, the hospice company, that will deliver medications for a very small fee, because most of us are juggling the busy life of working. We have soccer games. We have so many things that we're trying to do during the day that it's like, stopping by the pharmacy or having to pick up one more thing just feels like it can be overwhelming. We have a dentist, even though Medicare and Medicaid do not provide funding for dentist work. The dentist, we have a traveling dentist who will do anything from teeth cleaning to extractions, and we actually had a patient who had 7 teeth that needed to be pulled. She had them pulled, he followed up with them, and her quality of life increased 80%. She just became so much more able to get out, to feel comfortable about her mouth and how she can eat. So those are a few things that we've added. And then the LCSW, but our goal is to provide, and be able to provide spiritual care, be able to provide an aide that can go out and help with personal and grooming needs. Those are things that hopefully the palliative care program will make enough money down the road, years to come, that we can say, listen, let's have somebody come in and give you a shower once a week, or do your hair once a week, or shave you. But for now, we've partnered with community partners to offer it at a lower rate. So if they want to have private pay, they can go in and do that. So, yeah, I think it'll...
Well, and one of the beautiful things about hospice and the way they set up the benefit with hospice is that everything's included on a daily rate. It's capitated care. And capitated care is a very foreign concept to American medicine. It's a very common concept in European medicine. For example, if you're a family doc and you have Miss Jones to take care of, the government's going to give you X amount of dollars to take care of Miss Jones. Doesn't matter if she's in the ICU every day of the year. Doesn't matter if you see her once for a hangnail. You get X amount of dollars to take care of Miss Jones. Kind of makes sense. You know what your costs are going to be. And supposedly it all evens out, when you've got 1,000 patients, some are higher need, some are less. And that's the way hospice is. Hospice, you get the volunteers, the social work, the chaplaincy, the nurses, the aides, the doctors. It's all under one capitated daily rate. Now, palliative care doesn't have something like that. But palliative care is still, the physician is reimbursed just like you was if you were seeing someone in the office. And social work can also bill out for those types of things. And then the other expenses that, if there are needed, just have to be borne by the patient. If you have to have an aide, or if you have to have a caregiver because that patient is not able to be living independently anymore and they don't want to be in a different type of setting, then the family has to provide that. So.
And I think that with families, if you don't know what your resources are, it's very frustrating. If you have somebody who's starting to decline, or doesn't necessarily need to be in a home or need to be on hospice, it's the resources. And we all have been in a situation where it feels overwhelming that you forget even just how to start from ground zero and say, okay, task 1, task 2. And so we've had a few families that are so relieved to say, thank you so much for just finding the number for us so that we can call them and then we follow up with them. So it's nice to have that available.
I think the real challenge that I see, especially for physicians in palliative care, is to really find that point. We're getting a little better at knowing where the hospice point is. But really, where is that point where we go from conventional medical care to palliative care? And, the great thing about palliative care is it can certainly be done in conjunction with traditional medicine. I use the word aggressive medical care, but it's not really a very good word. It sounds negative. But, interventional type medical care. Because, eventually in chronic disease, we get to the point where, we don't want our mammograms and we don't want our colonoscopies. And it's not that I mind the colonoscopy, but if you make me do that prep one more time, it's, and what we start to see, there comes a point in people's lives where we find that those interventions that a 20-year-old tolerates this fine. If I had a nickel for every time I sat down meeting a family for the first time and I'm taking care of grandma, and grandma was doing great, 10 years living on her own, 90, just tearing it up with the grandkids, and and then she fell down skiing and broke her hip, and she had that hip surgery, and it's just done ever since then. There comes a point in which aggressive interventions don't recover as well, is the best way to say. And that to me is really the time in which you really start to focus more on palliative medicine and less on the interventional type of medicine. But where that point is can be very hard to pick out, and I can tell you that primary care doctors and specialists are even worse at trying to figure out when that is. That's just like that 90-year-old blind diabetic dialysis patient in the nursing home. In that orthopedic surgeon's mind, that point never exists, and what limits a lot of our care in medicine is, well, I can't do it because, you know, it'll kill the patient. That's when they kind of finally say, well, I'm not going to do that. But believe me, there's a long line or time period before they get to that point where interventions like that just take a major toll on people and really shouldn't be done. But it's really that's really to me the art of the palliative deal, how you can figure out. But if you're a primary care doc and you're really involved in your patients' lives and you know your patients and their disease processes, then you should have a very good feel for whether a major intervention is really going to improve their quality of life and get them back to where, or just, you know, take them on a downhill slide that is really going to affect their overall health. And so, you know, you may opt not to do that. I think that that's something that it's very hard to teach. It's something that if you have it in mind and if you enjoy that type of practice and if you really care about your patients and you feel like that's the best thing for them, then you will learn that type of medicine. And I think good primary care docs have that. But it's certainly not anything that they're teaching in med school. So, and I think not only is it good for the patients, but it's something that has to occur in American medicine because we can't afford to do what we're doing, you know. But as long as you've got a payer source, then you're going to find a doctor who'll do it, you know. And so then maybe that's the way to correct it. So you just quit paying for it. That's the way Europe does it, you know. If you're on dialysis and you're 70, you know, and your kidneys quit and you don't get dialysis, you know, in Europe, unless you want to pay for it. So they start limiting things.
So I'm wondering if you guys have, if anyone has questions about palliative care or hospice care specifically that you think Gary could help you understand. I know one of the things that I wonder about when I think about palliative care specifically is when you go into a patient's home, is there like a number one thing that you see pretty much across the board that people who are needing care in their homes benefit from? You know, is it like med management? Is it seeing what their home atmosphere looks like? I mean, what is it that you see that you think isn't uncovered when someone is coming to the office?
Yeah. Well, I mean, I think that you're always trying to drop back and kind of look at the whole picture, and that's one of the beauties of actually providing care in the home. You know, I think when people go to the doctor's office, and I've certainly practiced that type of medicine, you know, they've got their Sunday best on, especially the older population. I mean, they just love to see the doctor and to look their best and put their best foot forward, and you just don't have a very good idea about how things are really working at home. But when you go to the home and they're still in their pajamas in bed, I mean, you get a pretty good idea of what's going on. You know, and you can look and see how many throw rugs are on the floor, and so being home visits really helps, I think, identify those types of things. And I think the biggest thing, you know, for me is really medical management. I'm still a doctor of medicine, and a lot of the ways that I see to palliate symptoms do involve medicines. And so when, you know, and I might even have from the home health, you know, the list of medicines that they're on. And then it runs the gambit from everything of, oh, I see that you're on these 5 medicines, you know, and then, you know, they bring out a shopping cart of, you know, of pills that they have in the house. And literally, I like to go one by one. All right, this is this. Do you take this? Oh, yeah, I take this. Well, it's not on your list. Well, yeah, I forgot to put it on the list. You know, I mean, it's amazing. And when you finally come down to what you're really taking and what you're not taking, or sometimes duplicate medications and medicines that we thought they were taking that they're not taking. And this gets very confusing for patients and for families. And a lot of our patients, their brains just don't work that well. But they, you know, I think of one of my patients in particular. He's in an assisted living, but he can't afford to have the assisted living do the medications. And I walk in and I say, now, you know, I heard you're running low on your blood pressure medicine. And I mean, literally, this he's kind of a bit of a hoarder, and he's got bottles everywhere. And he says, oh yeah, this is my blood pressure medicine. And he picks up the bottle and said, no, that's your prostate medicine. You know, and I mean, and it's just chaos in there with his medicine. And as a doctor, I just throw my hands up and go, how do I manage medically this person who can't afford to have help? And I don't, you know, so Yeah. How do I? I'm not doing a good job. I mean, I'm trying to find funding sources to help them. You know, does he have the VA benefit? Does he have this? And you're working with families, and so far they just, you know, I mean, but the truth is, he still likes to. He has no business driving, but he has a car, and he still wants to drive. And if he gave up his car, he could afford to have them, you know, for $150 a month manage his meds, but he won't give up his car. You know, so you just try to help people, but it's like I tell them, I'm just your doctor, I'm not your mother. This is what I suggest. You know, they seem to understand that when I say that. These are all suggestions. I'm not here to make you do anything. They kind of seem to like that too, because a lot of doctors, they don't really speak from that perspective. You know, this is what your problem, this is what you need to do. You know, it's not like do it if you want to do it. But, I mean, if you're a smart doctor, you realize that's the way patients are anyway. But most people just feel this impelled, this terrible, that they must to do it because the doctor said it. But I try not to be that kind of doctor, you know.
So I just wanted to comment, that sounds like a typical hospice admission to me, what you're describing in many cases. So getting that prepared ahead of time somehow and starting that would be awesome. But I'm wondering, do you run into the concept of giving up hope during your palliative care recommendations, I guess? Is there a sense of that? Because that's a situation that hospice does.
Like giving up hope that
You're not telling me to fight anymore. Let's talk more about more common sense.
Yeah, I mean, certainly in hospice, that's something that we deal a lot more actively with. But I find with palliative care, this is really what patients want to do. And so it's really just kind of giving them choice and helping them enable them to do what they want. You know, and if they choose to do those things, that's great. As long as they understand it, as long as they get the perspective. Because I think that it's very hard for, I mean, we all have informed consent and all these bad things can happen and stuff, but we never think they do happen, right? That's why we still want to have our procedure. But, you know, if you say, look, I mean, really, this is, if we do this, if we go down this road, certainly could help you in this respect, but the great likelihood is your quality of life is going to be diminished, and for these reasons. I think real informed consent, you know, about what really happens. You know, to folks when they get frail and elderly, and we're still doing very, you know, aggressive interventions.
Sounds like you're saying that you give people more permission to do intuitive medicine, and then to sort of oversee a bunch of different providers. Because if I were seeing 7 different people and they were all telling me to do one thing and not giving me maybe the choice that, or I'm not, you know, active enough to say I don't want to do that to my provider, but you're sort of giving them permission to do that in the home, which is different.
Right.
Is that
Yeah,
like coordinating medical care also, not just prescribing or?
Yeah, and then giving them a professional perspective on something that they just don't really, I mean, they know they have the specialist's opinion, and he's the specialist, but they don't necessarily have someone who necessarily knows a lot about medicine giving them their perspective, you know, on that issue. Yeah, I think that's a good way to say it. But I think hope-wise, so, you know, in palliative care, because they're still very much in the driver's seat, and if they choose to, you know, have radiation or chemotherapy, or you know, with cancer, or you know, a cardiac cath and a stent done because they're having angina, or I mean, just any type of particular intervention, or yes, they've got you know, a lump in their breast. And you know, how aggressively should they work that up? Or their PSA is elevated, how aggressive should they work that up? You know, it's those types of things that you just, I mean, certainly the American medical system is cure. I mean, there's no doubt what you do with the lump in the breast. I mean, you cut that thing out, you know. There's no doubt what you do with an elevated PSA. I mean, you irradiate that thing. I mean, that's the way American medicine is. It's not, well, does it really make sense for your mom to do this? It's just trying to make sense of it.
Well, that's how nursing is too, I'd say. Well, for all us nurses here who go through school, we don't get taught hospice. I think there was one page in my nursing book. It's all cure, be rid of these medications, and oh, like you said earlier, don't get more than 10 milligrams of morphine. Oh boy, be afraid of that. And
Right.
so it's a definite cultural issue, I think, as well as that is an issue. You kind of got to get in somebody's head, and if you can, to tell them it's okay to make their own decisions. You're not completely dictated to by the medical system. But we're so indoctrinated to do what the doctor says, especially the older people, the older population. Like you said, they dress up and they do what the doctor says. My own father was that way for a very long time. Yep, doc, I hear you. That chemo is not going to have any side effects. I'm going for it.
Right. Right. Well, that radiation, it's benign stuff. Yeah, and it's funny, families will tell me, look, you got to tell my mom this because you're the doctor and she'll listen to the doctor and she doesn't care what I say, you know. But it's like, I'm not really sure that's in her best interest. I don't think I should really tell her to do that. You know, but they want you to tell her because that's what they want their mom to do. So it gets hard. Tell you, if you don't like psychosocial medicine, one, you'll hate hospice, and two, you know, you won't enjoy palliative care much. Because you just have to really, one, be willing to take time. You know, and when I sit down with a family, one of my patients, and the main way that I actually get patients is in assisted livings. I have several that I work in and have a close working relationship with, and you know, they're moving their grandma up from California because her husband just died, and she just is not doing well at home, and they're going to bring her up here to the assisted living in Utah. And that's when you get to first meet the family and the patient, and those are not good situations for the most part. And you know, very stressful. Everybody's got a different idea. Grandma's definitely not happy about it, and you know, and so I spend an hour and a half with, and Alethea can't figure out why I'm not on schedule. It's like, yeah, 15-minute office visit just ain't gonna work, you know. It's, you know, they don't try to schedule me that tight.
Do you work at all with palliative sedation then, or does that always go over to hospice, or do you work in connection?
Well, I do a lot of hospice. I probably have 500 palliative care patients and about 100 hospice patients. And so palliative sedation is certainly something that we do in the hospice field. And in fact, we were having lunch and talking with Kit, and we were talking about some of these really difficult cases that we get, you know, and you know, we have, you know, plan A, and then you got plan B, and then, you know, you hopefully got plan C, and if that doesn't work, you ought to have some ideas about D, you know, that you really have to have, because it doesn't always work with everybody, you know. I mean, you get, I'll never forget, I had this one guy, had a brain tumor, he was dying, but he was young, and so his body's still strong. And of course, he's loaded up on steroids like crazy. This guy's probably 50-something. And you know, out of the blue, he basically developed gas gangrene in his leg. So he had his purple leg with blisters with bubbles in them. That's how you know it's, I mean, I didn't have to send a biopsy. I mean, I've seen enough gangrene in the third world to know what gangrene is. And Clostridium difficile, I mean, not difficile, but perfringens. And so this guy, and I tell you, you know, it's basically just eating your muscle. It's a very painful thing. Morphine, nothing. Add the benzodiazepam, nothing. You know, then you move on to the next. You know, and so it gets very challenging. You get people that just the regular stuff doesn't work, and a lot of these people have already been on a lot of narcotics. You know, it just doesn't work. So you better have a lot of things in your bag. So,
You said he was young and 50.
yeah, young and 50. Yeah, he was stinking young for me, you know. And so, yeah, so I mean, we're looking at anesthetic drugs. In fact, Kit was saying, you know, what do you think we can get hold of propofol? You know, it's an anesthetic drug. Most anesthesiologists don't like you messing with that, because that's their deal. Even when I work in the ER and I'm having to, you know, reset somebody's fractured arm, you know, and if I want to use something, sometimes the anesthesiologists say, no, we want to control that. We will come down and do it. So it gets tough to get hold of those drugs. So, but yeah, we do a lot of palliative care. palliative sedation.
Oh, go ahead.
So is social work involved in palliative care? Is there a means to pay for social services? Because it seems like it's a process for somebody to really come to terms with where their life is and your good information, but yet the emotions that go with that can be addressed by social work. I think is really a good mix in getting people, thinking and dealing with that process.
Yes, Medicare will reimburse for that. Most insurance companies do.
But it's a certain level of social work. Let's say it's
Right, you have to be an LCS, like a clinical social worker. Be able to diagnose and then develop a plan of care for that diagnosis.
So if a person has VA, Veterans Benefits as their primary care, and Medicare, then for those social services, do you know if the VA will cover that?
I'm not aware of whether they will or will not, but if they do not, then Medicare will kick in secondary. Yeah. No.
The VA is often more flexible than Medicare as far as what they will cover and what they won't, and it also depends on the plan that that person has.
Yes.
So it's very unique to every person. So we always encourage anyone who has VA benefits to let our social workers help them tether out, like what is it that will be covered or won't, and sometimes even things that may not have been. Once we get in contact with the VA and say, here's what we're looking at, they'll say, oh yeah, we'll cover that. So that's a different sort of plan than Medicare, where their rules are very rigid. If we do, we don't, and that's
if the
kind of
person
it.
is a disabled person.
Yeah. Oftentimes it's even better
Well,
for coverage, for sure.
Not even a disabled vet. I mean, we had a Lou Gehrig's patient that was probably the longest living Lou Gehrig's patient in the country. So I had it for 8 years when he came on hospice, just died last week after being on for 9 years. And he had it through the VA, but he was a healthy, amazing guy before, athlete, so he wasn't a disabled veteran. But I'm telling you, the VA, I mean, you want a special chair, bam, you had a special chair. They would come in, they would redo his house. They would get him communication equipment. I mean, I was blown away at what the VA did for them. I mean, they snapped their fingers. Those guys couldn't help enough. I was amazed.
I've observed that as well.
Mhm.
Yeah, it's really neat.
Yeah, that's wonderful.
Did you have a question?
I did. In the palliative cloak alleviate comfort continuum of care, you said plan B, plan C, plan D, nothing's working. Would you mind talking a little bit about your views on physician aid in dying at the end of life in the continuum of care?
Sure. I mean, obviously, in Utah, of course, we don't have any physician-assisted suicide, I guess is the way to say. But I mean, all my patients are dying, and my hospice patients, and really all my palliative care patients.
Well, we honor
And all my pediatric patients. And so, but yeah, there's always that hope. And so, my job is going to be to relieve pain and suffering and in any way. And if that means that you're not going to be eating and drinking because you're just going to be in a comfortable place and resting, well, then that's where you're going to be. I mean, my goal is always to do those symptoms and make you as functional as possible. But if I can't produce that, then I'm going to use whatever it takes to make you comfortable first. I don't care what your blood pressure is. I don't care how well you're eating and drinking. I mean, comfort is number one. And so, and I explain that to them, and that's generally what they're most interested in. And if that means that it is going to, and it surely will shorten their life. I could help these people live a lot longer, days, weeks, but that's not the goal. And so I have no problem doing that because that's my job.
But physician aid in dying in Utah is illegal, correct?
Right.
So that's not something that you would practice.
Right, and I just heard a nuance that I hadn't even thought about before, that endorsing stop eating and drinking could be construed as physician, not aid in dying actively, but it's a well, this is an option for you in this situation that you're in.
Right.
Versus the proactive physician aiding dying as it is in Montana. My question is about the dialogue as a physician. I really like a lot of what you've said about how you approach cases and Plan A, Plan B, Plan C, and all of the tools that you have to use. I'm just so encouraged by that.
Well, and I think it becomes difficult for me personally when I have a patient that is, you know, doing reasonably well, but just ready to go and really asking me to do things that their level of certainly physical and even as far as I can perceive emotional pain is at that level, but they're, you know, wanting to, you know, be on a pump and be asleep. You know, I mean, then I struggle with that, and then we're going to have a dialogue and, you know, try to get to a place where we're both comfortable with, whether that's a week down the road or whether that's going to be tomorrow, and you know, everything's different. I mean, I realize that my interventions are going to shorten some people's lives. I'm okay with that. You know, I'm still a long way from okay, me personally, doing something actively to end someone's life. I mean, that to me is still a big difference, and something that you know, that I'm personally not comfortable with, and nor is it legal where I practice. So, but then that can be there can certainly be some gray areas in there. So.
Gray areas not always physicians.
Yeah.
And I'm a cancer doctor. I've been doing that for 30-odd years. And I often have patients end their life, they want to end their life, they're in the hospital, and I would say, morphine drip, try to titrate to comfort. And what I found, this resonates with the comment you made a minute ago, it depends on the nurse.
Oh, right.
And I can predict, you know, who the nurse is going to be on that night, whether that patient will be there in the morning or not.
Right.
Some nurses refuse to change that morphine drip. Some will see pain in the patient's eyes and say, "We're going to go up."
Right.
And
Right.
I can absolutely predict it. And which right and wrong, I'm not going to tell you, but I can actually tell you that if I think someone's time for someone to go, I say, well, why don't we assign her to her time rather than someone else?
Right.
Do you find that the conversation about the physician-assisted suicide comes before, like at the beginning of hospice, or at the moment when they're really suffering, or how often would you say that?
Well, when I'm talking to somebody about pain and pain management, I just try to lay out there what people's options are, and let them know that is because a lot of people don't even necessarily know that something like that exists, you know, and to let them know that is a possibility, that if I cannot control your pain in a way that you can be functional, then I will put you to sleep. And whether that takes Versed, fentanyl, ketamine, and phenobarbital all at the same time, then that's what we'll do.
But do you find that they're asking you those questions before they've even gotten into that situation? So that it's the fear of being in pain. Right. I think a lot of times they'll be like, well, can I make sure that you're going to do this? Because we haven't gotten there. But I think there are some studies that have shown that some people were given the materials or drugs to be able to do that, but they got counseling, spiritual counseling, and then they didn't even end up using that because there's a process in this life and death. And so I think that a lot of times it's just that fear of, I want to know what my options are.
Right. And it's not only the process of knowing and the fear of not knowing, but it's what giving people control over their destiny does. That you know, over half the people that get the agents to commit physician-assisted suicide don't use it. That just is an astoundingly large number when you first look at it. But then when you realize, you know, gosh, you know, that just seems like a waste, you know, but superficially, that this is someone who now has lost control of everything in their life, but they've got control of something. And they don't even have to exercise that control. But it's just the fact that they know they have control now that makes life worth living again. that they don't have to do that.
I've been a hospice nurse for 8 years. I've only had 2 or 3 people ask for that sort of care. And it was at the very, very end, and we went through the process. You titrate medications, you reassure them, you gain trust. And these were all younger people, similar to what you're saying, who had incredible, I believe they all had cancer. They'd been in bed for a year. They were emaciated, essentially, and they, in their mind, had said everything they needed to say to family. They had met all spiritual goals and life goals, and it really takes a lot, from my experience, to get people to where they're that ready. And they have had all these choices all along, and have been able to participate and make their own decisions. And okay, maybe that fentanyl patch isn't working anymore, and we're at 300, 400 milligrams of fentanyl patch, and maybe it is time for the pump. Do you want to go there?
Yeah.
So you're going down that route. It's not just I'm on 10 milligrams and working, and tomorrow I want to be on I want assisted suicide. It is a journey, and most people don't, to my experience, don't need that or even ask for it. It's certainly not an initial conversation unless someone brings it up.
I think in layman's terms too, there's a huge difference between physician aid and dying and terminal sedation. So we're kind of blurring the two, but there are definitely different options.
As well as assisted suicide.
Right, that's something.
Physician aid and dying.
Palliative sedation or terminal sedation, they're different things. And in different states, the laws are different.
So what I'm hearing, and Deb, you said this too, is it's about patient-centric care. That it is, they get to decide with you in a collaborative way.
It's amazing.
So what I heard earlier, what I'm trying to find out is about this movement of palliative care and how all of us, being consumers or people that are in the industry, can move this along. There's 2 questions here. One was my understanding that there's a demonstration project on palliative care without a hospice diagnosis that's covered by Medicare in the Affordable Care Act. And I just heard that once. I don't know, so I'm going to ask you the question. And then secondly, how do we get to a place, how do you think we get to a place that it is patient-centric care, collaboration, a little bit more like the European model, because we are not going to have those resources to take care of the hundreds of thousands of older people who have chronic disease. So if you had a crystal ball and you said, this is what you can do to help move it forward, what would you say?
Well, I think the thing that really is going to change the system and what really drives the system is money. I mean, I hate to say that, but in most things in life, when we look at what's motivating or what's making this process work, it's unfortunately a lot of times money. And so money is going to be what's going to change it, because you're already seeing it in Medicare, and as the government. And gosh, I could jump on so many soapbox right now, but I'll try not to. But the government doesn't feel like it can limit things. They've tried to do a few things, and well, I mean, this is the best example that I can think of. We at one of the palliative care conferences, we had a senator or a congressman who had put forth the law or pass a bill that said that we want to reimburse your physician for having a conversation about end of life with you. You're not seeing him for pneumonia, you're not seeing him for back pain, you're just seeing him to talk about end of life. There's nothing in our code to pay for that, but we think it's important that you have an end-of-life discussion with your doctor. And who in their right mind doesn't think that's the best idea on the planet? And so this guy was I was a Republican until this. This guy was a Democrat that suggested this. I thought, well, that's a great idea. But I mean, watching what the American political system did to that idea was so ridiculous. I mean, so grossly misrepresented. Death squads, the slippery slope. I mean, I mean, as someone who is in that business, I just was appalled. And so there is this big thing in America that we, as a government, cannot say no to people. So what are we doing now? We're having AARP manage your Medicare, and they'll tell you no, you know. They'll slash your benefits, they'll do all those things. So I think, you know, we're seeing that the government is getting smart enough to get out of that decision-making process and let the private sector do it, you know, because they're motivated by money too, and you know, Medicare couldn't say that. So, but I think that's what eventually is going to happen, is that it just needs to start being limited, and because we can't afford it, and money will drive it. And people who are thinkers and can look at that situation that happened to that Democrat who was trying to pass that one death squad bill, and saying that's ridiculous, you know, and changing the people you put in Congress and things. I mean, I couldn't vote Republican again after that. I mean, you know, I just couldn't do it. It made me crazy. So
I always like to tell all our hospice families, if they've had a positive experience, the best gift you can give is to spread the word of positive, that hospice is not a death sentence, that it is a good thing at a grassroots level. And if that's all I can do at the end of every patient situation, then I feel like I've done what I can in my little world. And it's a slow process.
Goodness travels faster.
Yeah, but I think, you know, when we're talking about palliative care specifically, you know, if we can share that it is a cost savings to have palliative care. I mean, we've proven that with hospice, and so I think that's why Medicare started to cover hospice, was because they could see that that was less expensive than what other people were doing at end of life when they didn't have hospice care. And I think if we can show the same thing, and there have been studies that do show that, if we can spread those studies around and spread that word about cost savings and show that through programs like this, where they only have 2 pieces that are covered by hospice, maybe the rest are volunteer, but at the end of the year you can say, even if those pieces hadn't been volunteer and they had been covered, here's what the cost would have been with palliative care and without palliative care, because that's where you're going to see that sort of answer. They're going to say, oh yeah, 3 days in the ICU is worth 30 days of hospice. Well, yes, hospice sounds like a great idea, right? So it's those sorts of numbers that are really beneficial at the end of the day when you're talking about a palliative care program, so track that. Like, what else are we doing for free? And how would that be a cost savings in the long run if they hadn't done this? Right. So, I mean, that's a heck of a lot of work to do.
Totally agree, but I think part of our challenge on top of that, and as one of the layers of all this, is dealing with, again, our cultural challenges and just the emotional component of facing the fact that we're all going to die.
Sure.
And so a good part of our society can't say that sentence.
Yeah, they have all those amazing studies of college students that they said, you know, do you think you're going to die? And something that 42% said, no. Okay, well, at any point in your life, hospice is a perfect conversation.
Television, how many ads for drugs are there now?
Oh my gosh.
It's just like a miracle cure for this and that, and the side effects will tell you.
Right.
And they are in the palliative care movement doing studies. In fact, I was reading about it 2010, I think it was in the New England Journal, in which they looked at oncology treatments of patients, and as well as they could compare, they found that folks who were in an oncology program that had a strong palliative care emphasis lived 2.5 months longer, was the number that it threw out. And so, you know, that kind of shook, I think, a lot of people in the oncology world to say, well, you know, it's not saying oncology is bad and that you shouldn't do oncology. This was not a study that said, oh, you're stopping everything and you're doing palliative care. This was palliative care with your, you know, so your depression is really getting treated, and so your quality of life issues are getting addressed, and those that just make good sense. But, you know, I mean, in medicine we only have so much time, and I mean, it's just that's just not generally in American medicine. But they're realizing that it's good for the patients. You know?
And I think that study was the lung cancer one, maybe, and that was a trifecta, so people live longer, had a better quality of life, and had saved money to do both at the same time.
Right.
And they did different oncology meds for one purpose as the other, but you think if you could have both, and it does all those things, why wouldn't you do it? That seems so intuitive when you see the study, and that's why it is sort of groundbreaking, you know, news.
I think sometimes people having to choose between curative and palliative, curative and hospice, all you've known your whole life is curative care. And people just want to live. You know, I think that's really the bottom line that we can't overlook, is that inside of all of us, we want to live. And to come to that personally, to where you are ready to say, all right, I'm ready to give up curative care, is to a lot of people saying, I don't want to live anymore. And that isn't what hospice is about. We're really there to help people live while they're dying, but because medicine is making them choose between curative and hospice care, the mindset is, I have to choose between hope and no hope.
Right. And that distinction is not in Europe,
Right.
in hospice in Europe.
And not only that, I think the travesty of it all is that patients are suffering through treatment. And by the time we get to meet these people, they are clear remnant of what they were because of the toll that suffering has taken on them. And it's physical much of the time, but certainly that psychological and that spiritual suffering that people have endured. And so, you know, I've been sharing with some of my colleagues, and actually have an article that I reproduced today to spread around. And it's an editorial written by Betty Farrell. So it's in the Hospice Palliative Care Nurses Journal. I think it was last month, so I think it was June. And she really encourages people that are in the hospice and palliative care arena to get more aggressive, if you will, in our I guess, desires to get people signed on earlier. We may be able to do that through palliative care. But essentially she's saying that, you know, if we don't look at the needs of patients, and if we identify suffering that we never address as physicians and nurses in a practice, it's malpractice. It's just malpractice. And, you know, you have to agree with that in some sense of imagination.
Isn't part of that suffering the anxiety, the depression, the isolation? I mean, besides the side effects, it's all that mental anguish. Sometimes doesn't get addressed.
I'd just like to put in a plug too. I think for in terms of just incorporating this conversation around living while dying, you know, that we're all in this, just incorporating young people too into volunteer programs through hospices and hospitals and what have you. It's really interesting to kind of do that piece, because you're introducing them into the idea of living while dying, and sort of doing that. Hospice chaplain, also a volunteer coordinator, kind of introducing that to high schools and to college kids, and they're interested, you know, and it demystifies this strange, sort of bizarre relationship we have with death in our culture. And that whole fear-mongering part of death.
And we have a big collaboration with one of the local universities, getting a lot of students volunteering. I think it's a great thing, because our society's, you know, still it's still mystified, you know, still.
They're inheriting all of that. I mean, we're being taken care of, you know, obviously by the generation. So.
I'm an old hospice nurse, and I have so many memories of different people dying in their homes, and one of them that just came to mind of talking about getting the word out there and getting younger people. I had a very, very well-attended death once. She had worked in the Catholic parishes, and so there were quite a few Catholic priests and just different people from the church, and it was just a huge gathering in the home, and someone came up to me and said, "Don't you think he should be in the hospital?" And at that point I could say, if he wasn't comfortable, if his family wasn't comfortable having him there, I just went through about 3 or 4 things, and I said, "So what do you see?" And it was like the whole education of that gathering was, yeah, why would he go to the hospital? He was comfortable. He wanted to be there. He only lived another day or two, but it was so educating of such a huge group at one time. Really sweet.
Right. Well, but there's definitely a population of people who really only feel secure when they're in a hospital. Well, they don't know that other things are available out. That's what they see that their destiny is, because the hospital can do the most when I need it. And what I tell them, as someone who's been in the ER a lot, and said, look, if you don't want me to put you on a breathing machine, there's very few things I can't do for you in your living room that I can't do for you. And I've taken care of people, on breathing machines in their living room, but for the most part, but it's definitely in the American psyche that I have to be in the hospital. Not that they want to be in the hospital, but that's where they feel a security.
Dr. Holland, would you mind talking a little bit about the different cases? Because I think we talked about, okay, what's unbearable? And that's such an individual thing. So a couple of just cases of what one person would find unbearable, another person goes, oh gosh, now that I have this, I can see myself living this way. And how, as people progress through disease stages, how unbearable gets redefined, if you will. What you see.
Well, I think that as a physician, you really have to really try to always see it from the patient's perspective. You can use scales and smiley faces and things like that to try to gauge people's. That's not always pain. Sometimes it's the misery level. They can't move. They're dependent on others. There's no dignity. I mean, there's just so many things that just weigh in on someone's level of discomfort. And I think it becomes a little easier when you're just looking necessarily at pain, but that is just as well a completely subjective thing from person to person. You get this old farmer, he comes in the ER and it happens time and time again. Are you and they're infarcting, they're having a heart attack, and it's like, well, what's your chest pain like now? And they feel like they kind of have to keep correcting the doctor. Well, it's not a pain, because pain to them is when they drove that 10-penny nail into their kneecap. That was pain. But this is not pain. This is, pressure, having this weird, so that everybody, and there's that guy who perceives pain one way, and then there's, the 20-year-old chronic pain addict type patient who will just be sitting there talking to you like this and going, yep, it's 10 out of 10. It's killing me right now. And how many of y'all have not talked to a dozen people like that this week? I have. And so it really becomes, you don't want to be the guy. To me, it's hard I basically want to believe people. I am going to, because I think that's their perception, and their perception is true to them, and just to really always try to get their perspective on it. Now, on the other hand, I'm also someone who really dislikes being jerked around, from a drug standpoint side. I've spent a lot of time in the ER, and probably a third of the people that walk into most ERs are just trying to get drugs out of you. So, I get a fair number arrested out of the ER. But there's a difference to me when someone is negotiating with me about pain control as opposed to, just trying to jerk me around and get narcotics so they can go sell them on the street. But sometimes this can be impossible to tell, and certainly, and even in our hospice patients, we know that there's drug diversion going on, in those situations. Sometimes by the patients, sometimes by the families, and so. Yeah, I think it's very difficult. I think you always have to fault, I'd always rather be faulted for being too generous and too naive than to ever be, stingy and and not take care of somebody who really needed it. So I'm probably end up taking care of a lot of people that don't necessarily need it in that respect. But I mean, that's just.
You're probably end up in prison.
No, I never worry about that. Even I'm sure Doppel knew half the stuff I do, they'd go crazy too. But you know, you can't live your life like that, I don't think. And I certainly can't practice medicine that way. So I don't know if that really answered your question, but.
I think part of the question is how we change our ideas as our disease progresses about what quality of life is.
Mm-hmm.
From day one, you know, like my quality of life compared to somebody who is being treated for stage 4 breast cancer, they're severely different. And how we sort of negotiate that as we live with a terminal illness or a chronic illness, you know, how does that look for you when you're coming into palliative care where you might be in the middle of those two things? Seems like more of a question.
Yeah. Well, that's when I'm really happy I have a lot of social workers to depend on. Because I think they're very good at teasing those issues out. Yeah, I mean, I think I understand the question a little more in the sense is when, well, it's gauging quality of care in different people's lives and then deciding how best to manage them medically given that quality of care. Yeah, I mean, I think it becomes difficult because a lot of times the person who is the patient is not the one who has the perspective on the quality of care, because they don't, I mean, you know, their mind doesn't work that well. I mean, you know, they're perfectly happy to sit in there and, you know, but their family is going, my God, my mom's quality of care has been crap for the last 5 years. You know, but if you asked her whether her quality of care was bad, you know, she might say, you know, no, I'm happy. But they know what she used to be and they know what she's like now, and they just see that as absolutely horrendous, you know, and don't do anything to prolong that. Don't even treat her bladder infection, you know. And so I think you just try to bring sense to the situation, because it's not really what I judge your quality of care to be. It's what I'm hearing from you or your family who's making your decisions as to what your quality of care or what your quality of life is, and to what degree of, you know, to what end do you want me to go to try to make that better. And you know, sometimes that's a simple thing, and then other times to me it just seems like, well, patients aren't really families aren't being aggressive enough. But I try very much not to have a judgment in that. And if you've chosen these people to make your decisions, then you know, it's not my place to try to tell them that I think that's a lousy decision. As long as I think it's legal and they really, for the most part, have their loved one's best interests at heart.
So then does that become to engage the family or the partners or whomever is around this person? Hopefully there's
it always seems
network
like
around this person,
yeah,
and they're not alone.
it's always a group effort.
Then that becomes part of your job as well, working with the doctor to find out a report, except that that's not really objective either, right? That's kind of subjective.
Right. Well, you know, behaviors in families don't change. If you have a mother who is a strong figure, she's now in her 80s, and her children they didn't speak up to her, they just did what she said, those behaviors will still continue until the later years. And so here you have this 80-year-old woman who's not taking a shower, who's not cleaning her house, but yet all the daughters are like, well, I'm not going to say anything, Mom. I'm not going to get yelled at again. I mean, you know, so then that's where hopefully we can come in and facilitate some services that are available to them through agent services, through if they want to pay for a service, then, but I think it's just realizing that you understanding the situation, trying to figure out what is happening and then not having an agenda, just saying, look, this is how we can help you and this is what we can help you with. But I mean, children don't change. They are in the same, you have the peacemaker, you have the troublemaker, you have the, they're all the same until, the one who's like, well, I'm not saying anything, you guys can figure this out, or so I think it just takes a little time and understanding through the physician, the nurse practitioner, and family members, friends, just to understand it.
I think for all of us, quality of life is a moving target throughout our lives. What we think of as what I thought of as quality of life when I was 20, when I saw my 60-year-old or 50-year-old parents, I thought, oh my God, I hope I don't get that old. It's just awful to me, And then I get a little bit older, and well, it looks palatable, and you get a little older, and it looks like it's okay. And I think as I age, my quality of life, it is a moving target, and I see it is going to change as I go on. And in that last part of life, I think it's still a moving target.
Might even be moving faster.
Find out.
And it seems working in a hospital, from that perspective, that the ideal, if it could be possible for spiritual care and social work and spiritual care of all kinds to be happening in clinics and in primary care, instead of just happening in the hospital and then falling away, that would be so ideal. But I don't know if that will ever happen.
Right, because it's not reimbursed, and so it comes out of the bottom line. But in the end, though, I think you would have more people drawn to the clinics and the places to say, well, it's not just about, I need a pill for this, or I need a drug, whatever you need. But I think it's coming from that place of the full circle of this emotional, the spiritual, the physical, and then in the homes, when I would go into the homes, I had to remember there may be a lot of turmoil, but everybody's trying to come from a place of love, and there's just a lot of fear right now. And so settling some of that then helps the process better. People can put their fighting arms down and say, okay, let's do this together. So that's the goal.
Thank you. That's a great thought. Yeah.
So at the end of every community conversation, what we do is put everyone on the spot, and we go around the room and just say, who we are and why we're here, and then what we'll leave with. So, and this is sometimes an emotional thing, but also, is there something that you learned tonight that you would share with someone else, were you moved in some way? Who will you bring next month to do a community conversation? Because really at a grassroots level, it is conversations like this that will help to make a change in the long run. So I'm sorry, you're in the hot seat. Don't sit there next time if you don't want to.
I'm John. My wife and I are dealing with the death of my son. I was here last month, and some of you may remember me. Basically, just to get more and more education about end-of-life decisions and what's available.
And you're going to tell people about?
All the way home tonight, I'll be telling people about
Out the window.
You really
I love
die
it.
yet?
Great.
And I wanted to add that my son died in hospice in Grand Junction, Colorado, and we were very impressed.
Wow.
He wanted to die at home.
Thank you for being here.
But when he saw hospice, he said, "This will be okay."
Wow. It's a big step to make, especially when it's your son.
We're all strangers.
All right.
You can go that way, please. No.
No way, Jose.
My name's Myron Gardapi. I'm a master's student. Kind of here to learn more about the palliative care, hospice stuff. Some of my interests lie in doing some grief therapy. So I guess that's the basic reason I'm here. And the things that I'm still trying to wrap my head around this whole the palliative and if they're going to transition from hospice to palliative eventually. You know, I don't know. So it's just kind of one of those things that I just want to know more about. So thanks for having me.
Hi, I'm Kayla, and I'm a retired hospice social worker. And I came tonight because I come in contact with people in my life who have parents or spouses, and wanting to help them and continue to grow in my knowledge and information about hospice and death and dying.
My name's Deborah. I'm an active hospice nurse and went back to school in my 50s just to become a hospice nurse. Became impassioned due to my personal life death experiences and a realization that people did not have to die in hospitals. I had no awareness of that in my earlier years. And I'm here to try to become more frequent participant, to try to make a community more aware and to make myself more aware of what's going on outside my world. I've worked in a variety of hospices and they all seem to be a little bit different. They all bring different things to the table and it's all good stuff. And hopefully I will be able to find somebody to come next time and do this grassroots thing. You know, that's about as powerful as I can be right now. Grassroots level.
I'm Mary Werner. I'm a music thanatologist at St. Patrick Hospital here. I've been just thinking of my parents the whole time this evening. They're both healthy and pretty well at 91. I have known about hospice for long enough and have wondered about that transition and how it might happen, but now I'm thinking about what you said about, you know, a good physician is hopefully also a palliative care physician at the same time. So I want to be more tuned into, I'm getting the impression that their care is that and that their physicians are being reasonable about what roads they're going down, but I want to be more tuned into that hand in hand with them. So it gives me another angle to look at that. Thank you.
I'm Lawrence Duncan. I'm a music thanatologist with Hospice in Missoula. And, you know, fascinated by this whole conversation and thinking about the history of hospice lately and wondering in that history in England, in Europe, if palliative care was part of the equation all along in a sense, or and how it is that, or was there a transition that happened? Did they go through what we're going through in terms of arriving at, oh, palliative care can happen outside of the end-of-life setting? And I apologize in a way for not asking that question already, but I guess I can look into that myself, or maybe talk to you later or something. But this other thing that was stated, you know, this question about a kind of a redefinition of malpractice has my attention too. I found myself, when you were searching for the right word, you arrived at discomfort, and I had already arrived at the word dis-ease. And it's interesting to me that we have taken that notion and narrowed it down so much to be one thing, when there's so much else going on that could be referred to as disease, that deserves being looked at.
Oh, how do you follow that? Okay. Other than bragging rights of now knowing the Latin root of palliative, which I'm going to brag about. I think that the best thing about these conversations is possibility, and how this kind of thing really will change the way we accept medical care in this country. I'm a social worker for one of the hospices in town, and this is brilliant. And I really feel like if we're talking about this, and you're talking about, Dr. Holland, you're talking about money's going to change things, but also this grassroots kind of social justice. This is what we want moving forward. We're going to vote our hearts, and things can change. And I hope they change. And I think it can't change without this conversation. And I'll try and bring a couple of my colleagues next time.
My name is Amy Hetzler. Thank you so much. I've been coming to these conversations for several months. I've missed a few. I learn something every time, and I feel like I have more tools. I'm here on with two hats, I always say, aging parents who are facing their end-of-life choices and what are we going to do. Another milestone reached this morning. I'm also here as an operative, I'm called, I guess, for Compassion and Choices. It's a national organization, and we are protecting the right to seek physician aid in dying in Montana. We were victorious in the legislative session this year, and I'm here with that hat on as well. But I appreciate this so much, and I appreciate the guest speakers.
I'm Cami Armijo Grover, and I guess I came tonight because I just feel like death and dying is something I've never been comfortable talking about, and obviously it comes up. And so I just wanted to have experiences like this to kind of get me more comfortable, I guess, talking about these sorts of things. And it's especially relevant in my life right now because I'm interning this summer in Missoula Aging Services, and so we deal a lot with older generations and people who've lost family members in a lot of cases. And I just don't necessarily always know what to say, other than I'm sorry for your loss, and I know that doesn't ever begin to make up for it. And so I was just coming to tonight to listen and learn, and I feel like I did learn a lot, especially the piece about it's not always physical that's the problem. Sometimes there's the emotional and psychological need that's greater. And I think that's a very common sense thing, and yet somehow I certainly forget it a lot. You just, when somebody has a chronic problem, or even when they just have a short-term issue, you keep asking them, how does it feel? Can we fix that? We're not thinking about the other things going on in the world that are like that they're not currently able to do, and how that might make them feel. So.
I'm happy. I'm a medical oncologist, and the palliative care concept, read about it in our medical journals, the oncology journals. A lot of oncologists say, well, what are they talking about? We've been doing that all our lives. Who are these people come in and tell us what to do? But the answer is, well, there's things they do. And Ken, Marie, and I are working on trying to get our oncology practice in town involved in this. We'll be able to do that because we do bring something different to the table. One thing that's very different is being able to go out in the homes and get eyes and ears. So it's my little piece.
I'm Kit Jackson, I'm the owner of Hospice in Missoula and Hospice for Utah, and I really have been excited about getting palliative care started both in Utah and in Montana because, of course, all of us that are in this world see a huge need for there not to be a 6-month prognosis for hospice care and to maybe get away from the H word so that we can adjust people's thinking to end of life and being more comfortable with talking. So I appreciate everybody being here and being willing to have this conversation with us because this is where it has to start for us to take it someplace.
I'm Laurie Swanson. I'm here with two hats on this evening. I lost my mother a year and a half ago. She was on the hospice benefit, and I really appreciated what hospice did for her and my family. And I'm a peer advocate with Summit Independent Living Center and work with the Transitions Task Force.
I'm Jennifer. I'm office manager at Hospice in Missoula. I come here, I think, we hear the term grassroots a lot, but to me it really comes down to community. And that's a word that seems to make more sense for me, and especially nowadays with work, you don't have that sense, you don't understand what your small town is. Families are segmented about the U.S. and elsewhere, so really understanding where we live and the people that we are around and the needs of the community that we're in and how to find those supports and programs like this is how we're going to build that beyond this place. So.
My name's Nancy McCourt. I'm a hospice social worker. And to build on the idea of community, I'm just so excited to hear that there are people from several hospice organizations here in the medical community and Missoula Aging Services, and it just is heartening to know that there's the true collaboration of minds getting behind comfort care. And then the little kind of humor defense mechanism in my brain is going, 10 years ago I was at Big Brothers Big Sisters, and they had to do a national study to prove that adult attention was good for kids. So now here we are, and we're needing to do studies to prove that people want comfortable, compassionate, convenient care. So, common sense, that's the other theme, I guess, in the community.
It ain't that common.
Thanks, everybody.
I'm Terry Steckley, and I'm an RN. I'm coming to you feisty tonight because I've been with patients today who are really, really needy. And I wish we could have met needs earlier in their trajectory. But I'm here mostly tonight because I worked in hospice a long time ago. I was a very young nurse that did that for 6 years, and then worked in a setting whereby we didn't discuss death at all outside of this country. And as I come back into the hospice practice, I'm looking around and going, gosh, oh gee, like 20-some years have passed, and we're still working to make this better for people. And we've made a lot of progress, but we haven't made enough in my mind. And so I think if people like us get together, talk about our ideas, collaborate certainly between different interdisciplinary fields and then also the agencies, that we'll
My name is Kathy Scribner. I'm a hospice chaplain and bereavement coordinator with Rocky Mountain Hospice. And for a long time, for several years, I've seen from the spiritual, psycho-emotional, psychosocial realm the need for palliative care, working with these elderly people sort of trapped, lost in facilities, in that in-between place, and knowing how much a team, like a hospice team, could help. And just wanting, to be part of this movement somehow. So I'm really excited that this conversation is going on, and I think we will build it from the ground up, especially in a place like Missoula, I think. So thankful. Thank you for coming.
Jackie Johnson. I'm a retired RN, and I have the privilege of becoming not exactly the first patient care coordinator for hospice, because Vicki Wright did it for 1 year before I came on board in 1981. And so we were autonomous, but we were apart. We had all the interdisciplinary team, and I don't know how many of you know anything about the origins, but it was amazing. And through the years, I've used my hospice. I've been back in, worked with partners in home care and hospice and all sorts of things, and Missoula Aging Services. And now I'm working as a volunteer with the Alzheimer's support groups, and there's 2 groups, and I really encourage you, and I do have some cards if anybody knows of someone who needs a phone call or needs a support group. It's amazing, and one of our faithful members, Lee, has been coming to this group and mentions it every so often about how helpful it is, and he continues to come to the Alzheimer's support group even though his partner died almost a year ago, and just because he wants to continue being helpful. And I love hearing people say, when I first came, I thought I'd just come for once or twice, and never thought they would begin to feel like a support group was kind of like family. And so now I'm in my sunset years. I feel a lot what I was able to do with hospice. And I do phone support and meet with people one-on-one or with families as well. So I am very, very honored to do that, and it's great. So nice to be here. I'll continue to remind people this is important. Sharing place.
My name is Cheryl. I'm here because Jackie invited me. My mother died under care of hospice about 12 years ago, but even though she had a kind of a geriatric physician, I personally think that hospice was called in too late. And so the family, she wanted to die at home. And so we sort of, my brother and sister and I, you know, kind of found a nurse and found our pastor to come and found the neighbors and tried to put together something to be around her. And then hospice was called in. And one thing that I will never forget is the care that hospice gave to us in the months following her death. That was of great support to me, and I realize now that I did not utilize it the way I could have, but I just didn't. I was so exhausted and grief-stricken that I didn't use the resources. And so I want to make sure that my family and my husband are on track this time. Glad to be here.
My name's Marika, and I come because there's wine. Well, that's not a little crazy. Yeah, well, I tried to sell you on it, but you're like a no-go, so I drank yours. It's fine. You know, it's interesting because last time I was here, there was a woman who had come, and she's come to many, and she's struggling with an advanced illness. She has cancer, and she said, you know, there are two things that I've always been afraid of talking about. One is pooping, and one is dying. So guess which one I'm still afraid of talking about? She's like, I don't want to talk about pooping still. That's great. That's great. But it is, I mean, that is such a rewarding thing. To hear that someone has changed such a huge piece of themselves by being comfortable enough to be in a conversation like this. So that's why I come. I come to help people move from not being afraid of dying to talking about end of life. And if you're still afraid of talking about pooping, I'm totally okay with that. So thank you all for coming and for sharing such intimate pieces of your lives and, you know, questions that we're afraid of asking outside of a comfortable area like this. I think that does create a movement and certainly gives us permission to talk to other people about it. So thank you for coming.
My name's Greg. I'm chaplain of Hospice in Missoula, and boy, one of the things that I'm still just kind of sitting with is that that point you said where we transition into palliative care, and I'm thinking about all the palliative measures we do in the midst of that curative care, and I don't see it, I'm not seeing it so much as a transitioning into palliative care, but emphasizing that that's available. And then with that is this team idea, this not just sending someone home with prescriptions and having them come back to their doctor, but taking care of all elements of the person. You know, I was thinking just a moment ago when we had our first son, we had him in a birth center and then went home, and you know, they were there the next day checking up on us, following up with us. They got us set up with resources so that we didn't actually have to go anywhere. And it was such a benefit, and those resources were inexpensive, and a lot of them were covered by insurance, and it was just, it made so much sense. And I just really hope that we can start introducing those ideas on the other end of the spectrum. When people, and you know, not just when people are dying, but when people are scared and lonely and going home. I think the palliative care model can be something that we can start being just a medical model, not a new program, but just a way that we see people and the way that we introduce. And I'm very hopeful, and I think this particular community here, and then, you know, where we're nested in this larger Missoula Valley, I think is a nice place to plant these seeds. So thank you for your words, and thank you for being here.
Thank you for having us. You get to cheer too.
Yeah.
You don't get out.
So I am Alicia Martinez, and I started at Hospice for Utah as a social worker, a part-time social worker, and then as time went by, opportunities came up, and you know, I just feel like my background and the people that are in my lives, that really there is a physical piece to it, but I also believe that the social, the emotional, and the spiritual piece. And so I try to make sure that when we're having our IDTs and the nurse is saying, you know, Mrs. So-and-so is just crazy. She's that crazy. Like, what can we give her? And, you know, I get to say, well, she's afraid. We need to figure out what she's afraid of, what's going on. And so I get to balance that a little bit, and I encourage our social workers and our chaplains. And so I feel like I get to help hold the torch to be able to say, don't just feel like you, because you're not a nurse or because you're not a doctor, that you can't disagree with what the nurse is saying. Let's come together and talk about it in the sense that there's no emotion behind it. We all just want to help the patient, but let's do it in every way possible. So that's what I get to do. And I just love being a part of Hospice for Utah. It's a great organization. Same as Hospice of Missoula.
I'm Dr. Holland. I'm sure I've done enough talking tonight. And I come for the free wine. Yeah, for sure.
Well, thank you guys all for coming. There's certainly more snacks if you want to stay and ask any questions from someone who met tonight. Dr. Holland will be here for a little while too, so we'll leave you if you have questions that have come to mind since you've been here. Certainly do come next month if you're interested. We are going to be talking about the history of hospice. The librarian who's coming is Suzanne from the University of Montana. She works at the Mansfield Library there, and she's done extensive research into end of life specifically, so around the world what different traditions are and where elements have come. She is like the trivia buff. In 20 minutes she taught me so many things I'd never even known, so it'll be really interesting in that way. So certainly come to that. And we've also started a new conversation which is even more casual than this, called the Death Cafe, and that is the second Wednesday of every month, and it is from 10 to noon at the Buttercup Cafe. And this is something that's an international movement, so it started in Europe, where at a cafe people will get together and talk about end-of-life issues, whatever that was. So sometimes people are talking about, you know, what happens after someone dies, or, you know, I had this experience, what did you think about that? And then a hospice is there just to facilitate as best they can. So it's very casual and it's kind of funky and a different kind of thing. You know, we found about it online, and I got some resources emailed to me from different people that I'm connected with in the U.S.
So if we gave you our email address?
Yeah. Oh, how do you find out about it? Yes.
Yes.
Oh, yeah. Send it to you. Just go ahead and sign up here, and everyone who's on the email list will send for both. Yeah. Oh, that's so interesting. Yeah. So that's it for me. Thank you guys so much for coming. Thank you.